Hey there, this is just a routine cataract surgery. This patient is having a Clearview implant placed. This is an unedited video. I'm just doing a voiceover to explain my technique and some of the things that we're trying to accomplish. That's a 1 mm paracentesis. This is a lidocaine and epinephrine mixture to maintain pupil dilation and comfort for the duration of the surgery. I use Endicote as the dispersive viscoelastic. It's part of the Duet system from Johnson & Johnson. 2.4 mm incision here. That's a Q-tip just because it's atraumatic. About a 2 mm length to the incision, and I extend that incision just a little bit so that it's wider than the 2.4. The capsulorhexis is initiated and completed with Utrata forceps. That second instrument there is just to stabilize the eye. I find that if the patient moves or if I need to align the patient better, that second instrument is really helpful. The second instrument that I use is the Singer sweep, and I use it for the entire case. I use it for nuclear manipulation, also capsule polishing to manipulate the implant, really for everything. This is an Akahashi tip for hydrodissection. I go all the way across the lens when I do that, just so that the lens doesn't pop out of the capsule. Just try to make sure that the lens is mobile before I start doing the phaco. I use continuous irrigation for the entire case. I try to initiate that before I enter the anterior chamber completely. I just find that to be more comfortable for the patient. The Singer sweep has an angle at the end there, which makes it pretty easy to get in there and crack these quadrants. The tip of that Singer sweep is rounded as well, which is pretty friendly for the capsule. I use the Venturi pump for the entire removal of the nuclear pieces. I don't move the phaco tip a lot in the sense that I don't go chasing things. I'll use that second instrument to bring the pieces to the tip. Sometimes I'll use the second instrument to smash the pieces into the tip. But it's mostly vacuum, not all that much phaco energy. Irrigation aspiration here, same thing with continuous irrigation. That's a little nuclear chip there by the paracentesis. I always go after those first so that they don't end up hiding from me and presenting themselves later. I'm just using the tip of that IA piece to manually remove some of the wispy cortical strands on the posterior capsule. It's hard to see that in the video. I'm using the Helon cannula right there for the same purpose. I'm just trying, as I advance some of the Helon, I will almost scrape some of the wispy cortical material off of the posterior capsule. This is the Singer sweep being used for anterior capsule polishing. I try to remove as much of the epithelial cells and cortical debris as I can. I'm going to have to move the microscope here while I prepare the implant. The insertion system for the Clearview is a little different than most of the other implants, so I fold these myself. I don't really have it here on camera. The system is pretty slick, but I didn't do a good job of showing you what I'm doing here. It's a plate haptic implant, and it has a hole in one of the haptics that will help you orient the lens properly. And I think of this implant as a progressive implant. That's probably not entirely accurate, but the orientation hole is in the near segment of the implant. And so most people at this point, I think, are putting the near segment of the implant superior temporally. That seems to do a really good job of giving the patient the result they need. So you'll see at the end of the case, I'll have the implant lined up in the distant segment, and the near segment will be oriented superior temporally. The funnel of this inserter, I try to get it all the way into the eye. That seems like a fairly aggressive maneuver there, but this does not cause a problem with the incision closing. It doesn't distort the wound. But if you don't get that funnel all the way into the eye with really any of these insertion systems, then the implant can get stuck in the incision, and that becomes a big problem. So to the right side of this screen is the superior aspect of the eye, and I'm just hydrating the incision there. I'm going to put some Dexmoxy in the vitreous cavity. This helps prevent infection and facilitates the healing process. Irrigation aspiration, I go behind the implant at first, try to remove all the viscoelastic from the capsule, and then I'll move the implant around to try to get it oriented properly. I sweep the angle, trying to remove the viscoelastic from the angle to try to prevent pressure spikes. And you can see in the implant that there is a sort of wedge in the implant. That is the transition zone, and I'm hydrating the incision here. I use a Weck to pull the fluid out of the interface. I just lay that Weck over top of the incision, and that wicks some of the fluid out of between the endothelium and the stroma, and allows those two layers of tissue to connect. The endothelial pump kicks in, and that closes the incision. I'll use my second instrument here to try to orient the implant properly. When I lay that cannula across the eye, that is basically vertical, and so the implant is offset slightly. You can see there that the two Purkinje images are lined up in the distant segment near the transition zone, but that's essentially perfect alignment. Subconj kinologue here as a part of the dropless procedure. This patient won't need any drops afterwards. And that's it.